we'll be discussing the effects of aging on the biomechanics of the master's runner. So we'll look at some of the physiologic as well as musculoskeletal changes of aging, and how that can kind of impact the different biomechanical changes, what changes occur in our master's runners, then briefly overview some interventions as well, and what things we might want to focus on when we see them in clinic. So what is the master's athlete? So USATF, there's some long distance runs kind of classifications for masters runners. Their cutoff is 40 years of age or older, but internationally it's usually closer to 35. And there are some in the US that are for 35 and older. So I would say the book answer is 35, kind of the accepted answer is 35 and above. And so for those of us in healthcare, that's quite a few of us. So master's athlete is, there may be a good chance that it's you. Certainly me. Why do we care? So care for a few reasons. We may think that, older you get, the slower you get, and maybe you don't do as much, but that's not quite true. So there's actually a lot more runners now who are masters runners. So the average age of runners has increased from mid 80s to about 5 years ago. It's gone up from around 35 to around 40, especially for the 5Ks and the 10Ks, since there's so many more 5Ks now, so many more 10Ks now. The average age for a marathon runner hasn't gone up a whole heck of a lot, but there's so many more 5Ks, and some people will think, oh, well, maybe I'll run a 5K, get in shape to that'll help me get in shape. But you need to be in shape to be able to run a 5K. There's a chance if you haven't done much, you want to go run a 5K without really any training, you probably run into our office as well. So risk of injury for masters runners is higher than the younger runners, as you might imagine. So a lot of those that become injured are more likely to have multiple injuries compared to younger runners, and it's actually a lot more soft tissue injuries, especially around the tendons. So calf, muscle, as well as Achilles, hamstring, both muscle as well as the tendon, and quad. Those are the big three for our masters runners. And also, we want to keep us running. That's why we want to care about masters runners. So just because we become masters runners doesn't mean we automatically become slower. Sarah Hall, Akira D'Amato, they actually ran their faster, if not fastest, races and best times when they were over the age of 35. With Kira, breaking the American marathon record and half marathon record. Brad Barton at age 53 ran a 4:19 mile, which is way faster than I can, certainly. And then Ed Whitlock, of course, running sub 4-hour marathons at age 85. He was running sub 3-hour marathons at age 74. So, just because we get older doesn't mean that we stop doing what we want to do or love to do, and honestly doesn't necessarily mean that we slow down a lot, especially for the newer masters runners. If you increase or keep the intensity and frequency of your training, you can get faster, not necessarily slower, and we'll get into that later. So I want to bring that up because the next few topics are a little bit more gloom and doom on how things get worse, and we're just always falling apart as we get older. So that's not necessarily the case. There are some physiologic changes, biomechanical changes that occur, but again, we can address that, and doesn't always get worse. So starting with the cardiopulmonary changes. So increased arterial stiffness means potentially increased blood pressure, decreased maximum heart rate. That's really more from 220 minus age, which is perfectly adequate unless you want to use a different equation. Decreased cardiac output, as well as decreased ability for the body to take oxygen from the blood. Then on the pulmonary side of things, loss of lung elastic recoil and increased airway reactivity, impaired gas exchange, as well as diminished forced expiratory volume, 1 second, which is not a precipitous drop off, but it does decrease as we age. And also our VO2 max goes down as we age. So this is the aerobic capacity, or the maximum amount of oxygen your body can use during exercise. This is the Fick equation. There's a few different ones you can use for the VO2 max, but this is really just cardiac output times the arteriovenous oxygen difference. So really just the amount of oxygen that you can use while you're exercising and potentially can be almost a proxy for fitness. So musculoskeletal changes, and I should say a lot of this is likely more related to um, activity changes as we get older, as well as just our maximum heart rate just goes down as we age, and that's unfortunately there's not much we can do about that. But the activity we can. We'll get into that later. Musculoskeletal changes. Um, so it's important to look at the neuromuscular system rather than just saying, oh, the muscles get weaker or the tissue changes. We have to take into account the neural changes as well. So we do develop a reduced neural drive as we age, so decreased recruitment, firing frequency and strength, as well as we have muscle sarcopenia, so the cross section decreases as we age, or is typically observed as we age. And therefore, with those two together, we get the muscle dynapenia, or decreased force production. And since we're, physiatrists, we want to look at the function, right? So if we have diminished force output, so that can potentially lead to functional limitation if it's severe enough, and potentially physical disability. Looking at connective tissue, so reduced connective tissue stiffness on the right, this is elastin, which doesn't figure into it as much as collagen, but it does to a degree, and we'll get into that. Whereas on the left, that's the collagen. So the collagen fibers themselves can potentially become, lose their stiffness, but also the interfascicular matrix around those fibers can degrade as well. And there's a lot more data coming out now that potentially that matrix of the IFM is almost more important than the collagen fibers themselves. And so in this case, you would say for the stiffness, almost like things feel stiffer, right? But mechanically they lose their stiffness. As you can see here with the elastin, just kind of degrades. It's not as crisp. It doesn't retain its form as easy. So the mechanical stiffness of the tendon, this is going to become a recurrent theme, especially over the next 10 slides or so. And so this is really important. Think of the tendon as a spring. When it gets stretched out, it will store elastic energy, and then once it stops becoming stretched, it shortens, it releases that energy. So muscles contract, tendons don't. Tendons stretch and then shorten. And so they're storing energy as they stretch, then as they shorten, they release it. And so if your tendon is not as stiff, it won't stretch as easily, won't store as much energy. Then all of a sudden, it could be overloaded, or there's going to be more force either on the muscle or the bone or just the surrounding tissues. And so it's really important to address, and that's something we'll talk about in the interventions later. So here's another demonstration. So you think of it as a spring, think of it as a rubber band. So on the left here, this is going to be, oh boy, if it'll play, playing just a little bit ago. There we go. So a nice, strong, healthy tendon. You can look how much elastic recoil there is. And I'm using about the same amount of force on both sides. This one is a little older, not as stiff. You can see it's not returning as much, doesn't snap back quite as easily. If we can kind of do a little comparison here, you can see the difference. So again, healthy tendon on the left, not so healthy tendon on the right there. Also tendinopathy. So we talked about just the overall decrease in stiffness as we age with a tendon. In a tendinopathic tendon, that also will have decreased stiffness and mechanical properties. And you don't see tendons with tendinopathy in younger athletes as much. You might see tendonitis, but you're not going to see the tendinosis or the overall almost degradation. And there's a lot of different health contributors that can figure into this. Hypertension, diabetes, obesity, hypercholesterolemia, physiologic stress can alter the tendon, or has been associated with tendon alterations. And you don't see, especially that full myriad of maladies in younger athletes. It's more of an older person problem, right? So that can compound essentially the aging effects on tendon if you have this underlying tendinopathy. And so how does this all kind of come together to change our biomechanics? So to start with this, I like to, when we're running, watching our runners run with a gait analysis, we kind of start from the floor up, bottom up. So foot essentially up to whole body. So we'll start at the foot. So you can lose the elasticity in the calcaneal fat pad as well as a little bit of atrophy. So this may compromise shock attenuation. As you land, as your heel or right initial impact, and this may explain higher impact peak forces as well as the increased loading rate that we'll talk about in a little bit. And potentially, if you have decreased stiffness of the connective tissue, including the plantar fascia, just from the windlass mechanism, you might get a little bit less propulsion from that. In the grand scheme of things, that's not going to be a huge deal, but that could be just a little bit less propulsion that you get. Our main forward propulsion comes from our plantar flexors, our calf muscles and our Achilles. And so there's a decrease in Achilles stiffness in our older runners, and overall decrease in plantar flexor performance. So decrease in the muscle cross-sectional area as well as mass, decreased force production, decreased power generation from the ankle, decreased ankle stiffness, that's mechanical stiffness, as well as decreased ankle excursion, so less range of motion throughout the gait cycle. Now moving up to the knee, so actually going to have increased knee flexion at initial contact, but overall less range of motion throughout the gait cycle, and decreased knee stiffness. So you think almost if you land at increased knee flexion, then hopefully you're absorbing more just through the muscles, but that's unfortunately not the case. Now there was an interesting study with Carol and all that looked at patellar tendon stress and strain, and at peak force output, it's reduced with aging. However, when they kind of controlled for overall force output, it actually doesn't change as much. So that reduction in the peak force output and strain and stress of the patellar tendon, if you control for the force output, it's not as different. So potentially that could be because the muscle's just weaker, hence the difference in the stress and strain. At the hip, there's not as many differences noted here. There's a little bit less excursion, so range of motion in hip abduction and adduction throughout the gait cycle, but really no decrease in power. And actually, older runners may almost recruit and get more power from the hip compared to younger runners when running at the same speed. And it's thought that may be to make up for the loss of power, especially forward propulsion coming from the calf. Overall, big picture here. So when you kind of take a look back, so it's going to be decreased step length. There's going to be decreased running velocity. You need to increase the cadence to maintain the same pace, but a lot of times this is not really done. So hence the decreased running velocity. Decreased center of mass oscillation, so not really bobbing up and down as much. There's not as much power generated up or forward, so it's just kind of staying along a little bit more level. A little bit more greater asynchronous between the ankle and knee movements during running, so not quite as much coordination. Then there is a negative correlation of vertical leg and knee stiffness with running economy, which at first glance, I might be like, oh, that doesn't quite make sense. If you want higher stiffness, right? But then lower economy, that doesn't sound good, but that's actually the energy cost per unit distance. So you do want a lower economy that's less energy used. Because again, if you have higher stiffness, those tendons are doing the work for you. They're storing the energy and then kind of giving it back rather than the muscles contracting and using up more energy. So in terms of the forces, while there's kind of less ground reaction force with pushing up as well as going forward, there's actually increased kind of absorbed force, especially at initial contact. So larger impact peak force as well as initial loading rate in our older runners, and the vertical impact speed is higher in older runners compared to lower runners. So almost taking more force at the initial impact and then not quite returning as much, especially with that forward propulsive ground reaction force, as well as kind of going up. So just to emphasize, as we land, as we get older, for our older runners, there's going to be more knee flexion, yet there's still higher impact peak force, higher vertical impact speed, as well as higher maximal initial loading rate. So just the force is not distributed quite as well. And this is even with a slower velocity and shorter stride length, which is usually what you would want to that would be almost your or at least the shorter stride length, and increased cadence would be your strategy to try and counteract that. But this is all happening in spite of that shorter stride length. So here, I just wanted to demonstrate this. Just kidding, this is truly me trying to run. So you can see not a whole lot of bobbing, really kind of surfing right along. I mean, there's a lot of issues going on here, don't get me wrong, but we're just going to focus on the things I kind of address with masters runners. So starting from the bottom, not a whole lot of forward propulsion coming from the Achilles. Not a whole lot of pop. There is, I wouldn't say I'm really at increased knee flexion here, honestly. So I don't quite check that one off. That's just kind of the way I'm running. In terms of the hips, I wouldn't say I'm necessarily using more kind of hip propulsion, but I'm also not trying to go at a real fast pace. So that probably does, that specific criteria doesn't quite fit here. And then, yeah, just not a whole lot of vertical oscillation. Again, just kind of gliding along there, and that is more typical of masters runners. So kind of shuffling gait, decreased propulsive force, as I kind of showed you with my running, increased knee flexion at initial contact, slower velocity, shorter strides, and that decreased vertical oscillation. Now, with the decreased strength and the decreased tendon stiffness, there's less force distribution, and that's likely what's it can explain the increased impact and the loading rates. And the weakness in the distal muscles, so the calf, and especially the Achilles stiffness compared to the proximal runners, seems to affect the gait pattern in older runners. And that decline in propulsion from the ankles seems to contribute to the age-related motor decline the most. So is it the body? Is it just the body's just falling apart as we age? The answer is maybe not. So this is a pretty longitudinal study looking at the aerobic capacity of 3 different groups. So one group did no training whatsoever. The other one was regular fitness training, and the other one was high levels, like intense, like essentially professional, semi-professional athletes. So those that trained at a very high level only had about a 6% decline in their aerobic capacity. Those who did kind of regular fitness training, about 10%, and the sedentary participants had about 15% of aerobic capacity decline. However, comparing someone who did absolutely nothing their whole life compared to a lifelong runner at 80 years old, that lifelong runner could potentially have about double the aerobic capacity compared to the inactive person. So, is it the body? Not a little bit, but that's not the whole picture here. So there is natural aging process. Yes, that can decrease your cardiovascular function and biomechanical function, but life gets in the way. As we get older, we have a lot more things, a lot more responsibilities, work, family, everything in between, that we just can't train as regularly, as intense. And so that all combined can decrease your performance, increase your injury risk. If you have more injuries, less training, and sometimes that can be somewhat of a spiral if you don't kind of stay in front of it. So what do we do? Nothing? Maybe work less? That'd be nice. But no, we need to try and introduce a lot of these different strategies to counteract that as much as possible. So resistance training is very important. Training frequency and intensity, flexibility, maybe a little bit controversial, but we'll kind of try and suss that out a little bit, and potentially gait analysis and retraining, especially if we're having those recurrent injuries. Now for the resistance training, it's a little bit harder sell for runners. I think it was Efren Cabalius, who's based in Denver, Boulder area, who kind of made the quip: runners don't want to lift weights. They don't want to pick something up and put it back down and pick it back up and put it back down. That doesn't sound fun, but it is really important, unfortunately. So just a quick aside, there's, as cliche as it sounds, our bodies are made to move. Our tissues are meant to be loaded. And so in this case, with the resistance training, it was found to improve the quality of articular cartilage in the knees. And this whole population was individuals who had a partial medial meniscectomy. So if they have less cushion in there and they're still doing this progressive weight-bearing exercise regimen and they're still getting improved quality of the articular cartilage, imagine what it's like if you have all your meniscus. So cartilage can get thicker, bones become stronger, muscles obviously become stronger, tendons become stiffer, all with this resistance training and this load. Same with intervertebral discs. Everything can become essentially stronger if you put the right amount of load on it. And so cartilage is no different. Here's an image from the study. So all closed chained, as it said, all weight bearing. So that is important. It seems to play a role, and especially the cartilage and bone is the weight bearing aspect. But just one more reason for runners to be lifting. And then to address the neural component. So lifelong strength training has a protective effect against age-related attenuation of the efferent drive. So this one study looked at older individuals who did either regular strength training their whole life or endurance training their whole life. And so that'd be essentially runners versus those who just went to the gym and lifted weights. And so they looked at the neural impulses, that motor drive, efferent drive. And even though the endurance runners were active, it's not like they were sedentary, they still had attenuation of that efferent drive. So the nerve impulses were not as strong, not as frequent, and the recruitment wasn't the same as those who did the strength training. And so that's really important to maintain that high descending motor drive, especially as we age, to maintain the maximum muscle strength. So again, it's not just the muscles, it's not just the muscle staying strong, it's the whole neuromuscular system that we need to make sure we address. Then for resistance training, so this is for both muscles as well as for tendons. This slide is a little bit more specific for tendons. A lot of runners want to do kind of endurance lifting, so maybe 20, 25 reps, because they're kind of worried about bulk, and that's understandable. But you're not going to get the adaptations that you need, especially with the tendons, if you're doing that many repetitions. That's also going to take a really long time. So we're looking more at 3 to 4 sets of 6 to 8 repetitions, and doing this 2 to 3 times a week. You don't have to do this every day, but going for that higher weight, lower reps is going to be much better for tendons, better for muscles, and actually better for running performance as well. So these programs, you want to be looking at least 6 months in length. Tendons take a while to adapt, especially, unfortunately, older tendons. They can take a while to adapt, on the order of at least a few months. So in order to really start seeing some beneficial changes, looking probably 3-4 months, but you want to go at least 6 months if you can, and then progress slowly, and have enough time in between sessions, especially for the heavy loading, because those tendons might need about 24 to 36 hours to fully adapt. Otherwise, if you do too much, too soon, too fast, it's always a recipe for outcomes, but the tendon might start to degrade rather than build up. So this is kind of looking at what we need to do to build up those tendons. So initially, get some increase in the proteoglycans and collagen content, may get some increased tissue density, potentially water content, but the key is increasing Young's modulus with the cross-sectional area. So if we have increase in cross-sectional area, but not the Young's modulus, then we're probably looking at more tendinopathic tendon where it's just kind of getting swollen. But we need to make sure that things are getting nice and stiff, and so it can handle that increased energy to return it. And as you can see here, it takes some time, unfortunately. The tendon can adapt, but it's not going to be right away. And here's the protocol from Silbernagel et al. So you can see that it's not just eccentrics. The eccentrics are kind of falling out of favor a little bit. This is specific for Achilles here. We're looking more at kind of slow, heavy resistance and progression. Progression is the key here. Other things, foot strengthening, which is always fun. So what 10, 20 years ago, it was all about the core strength. Then it was looking really more glute medius strength and kind of that pelvic stabilization. And now we're still moving further south. So we're looking at the foot. And there is some evidence that this can potentially decrease running-related injuries. This is the MOBO board this is invented by Jada Shari. Um, but working on foot strength, but almost more importantly is coordination and activation of the foot muscles to give you that nice strong foundation. So if you Google foot strengthening exercises for runners, you'll find a lot of the so some pretty good videos. But toe yoga, toe splaying, short foot or foot doming are usually the ones that I recommend. Um, and really trying to drive through that first ray so we can engage the all the foot intrinsics while we're running. Um, Training frequency and intensity. So as we can see from this image here, so aging, yes, you have decreased maximal heart rate. Unfortunately there's no way around that. There's really not. Maximal stroke volume will decrease. The arteriovenous oxygen difference doesn't decrease all that much. But all those three together, as they decrease, so our maximal oxygen consumption will decrease. That's a VO2 max. Lactate threshold doesn't change as much. Exercise economy, controversial on how much that truly changes. And potentially how much that really impacts performance. Honestly, there's a lot of controversy on which one is most important here. But either way, if we decrease our training intensity and volume, which again, life happens, in addition with the aging, then we're just not going to do as well. We're going to have poor performance. But if you can maintain that intensity and volume, you can potentially maintain that performance, or at least stay in the same ballpark. So examples of the intensity would be hill repeats and speed work on the track, which both of these are probably not as fun. Remember, a lot of my teammates probably hated these the most. I liked at least the hills the most, because that was the only thing I was any good at. But it's important to keep these pretty regular, even as we age. Flexibility training. So there's kind of a difference between the active tension, passive tension. As I mentioned, a lot of controversy on how important stretching is. Some people say stretching is a waste of time. You're not going to do anything, no matter how much you stretch. You're not going to stretch out the IT band, et cetera, et cetera. I somewhat disagree. I like stretching, especially for my patients who are not quite as active, just so they can have a little bit more, what's the word, kind of kinetic literacy. So they kind of get more in touch with their body, and they're able to move, and just moving can be helpful. For those who are more active, sometimes I think it might be a little bit more the active tension playing a part. Passive tension can certainly play a part too. I know Dr. Raiser will probably talk quite a bit more about the fashion, how that can be tight and throw things off for sure. But there's a lot of different types of stretching here. So static, dynamic, the pre-contraction or PNF essentially. I don't really recommend the static stretching all that much, especially pre-workout. I like more the dynamic stretching, maybe not so much the ballistic stretching. But the static stretching can decrease your strength, your force output for up to maybe 30 minutes or so. Whereas the dynamic, so think more like heel walks, toe walks, kind of walking lunges, a little bit of like single leg, like deadlift stretches, kind of going back and forth. So that's what I mean by dynamic stretching. And then ballistic stretching is like, swinging your leg back and forth. And that's, if you're an elite athlete, by all means, go ahead. But that's usually for someone who's a little bit more recreational athlete. I usually don't recommend doing that off the bat. After run, after workout, static stretching sure is fine, just as kind of a cool down that can increase your overall flexibility in range of motion. So can dynamic for that matter. But I'm not as adamant about the static stretching, especially before workouts. Finally, gait analysis and retraining. If there's a master's athlete who or any runner for that matter that continues to get injured and done all the PT, strength is fine, flexibility is fine, and just have these recurrent injuries, or something is just a bit off, especially if it's a certain mile. Like, yeah, mile 3 just always seems to get me. Definitely do a gait analysis to see if there's anything that we can kind of tweak, anything to address. so that they can just kind of get out of that injury cycle. So main takeaways, decreased force production for muscles and tendons results in these compensatory gait changes. Resistance training is really important for all runners, but especially masters runners. And we really, really need to pay specific attention to the plantar flexors and the Achilles tendon. And then, as much as possible, maintain or even increase training frequency and intensity to slow that performance degradation, and potentially that may increase the injury risk. So the more you train, the more intense it is, potentially, hopefully decrease the injury risk as well. And that's all I got.
This is great. Thank you, Rick. So for those folks who might have joined us a little bit late, this is Dr. Richard Lawley. He is talking to us from Loyola University in Chicago. This is our National Running Medicine Grand Rounds, our kickoff session, and part of what we want to do here is talk about some of the different running medicine clinics that we have across the country and connect folks. If you've got people who are traveling or people across the country asking who they need to go to, I'm hoping that we can start developing some of that network as well. So if you're in Chicago, go visit Dr. Lawley. So I wanted to touch on a couple of things. So a few things that I really like. Consistency through the course of a lifetime. So I think that's one of the biggest takeaways, I think, when we talk about masters athletes is staying active, staying injury-free is important, and being consistent is a lot of what I'm hearing. Another thing I really like, and I actually had a conversation recently with a patient, was about the kinetic literacy. That's a lovely way to put it. And so I was talking about mindfulness and simply using stretching as a way to get to know your body a little bit better. And I actually had someone tell that back to me before we had that conversation. So I think that's something that's super valuable, especially in folks who may not have been as active in their younger years and haven't done any of those types of activities, yoga, Pilates, those sorts of things. And I think there's so much value in that, just like there is with showing someone their run gait and doing some biomechanical education, even aside from the actual retraining portion of it, just getting people to be aware of the things that they're doing. Let's see. Rick, are you able to discontinue your share screen here?
Yep.
And while you're doing that, so I do have one question here that came through the chat. So the question is about suggestion of higher weight and lower reps. And they're saying, should this be for every muscle in the body? Is this upper and lower extremity? Should this just focus on the lower extremity? What are your thoughts on that?
So yeah, specifically for runners, I would say I was addressing more the lower extremity. Overall, if you want to build strength and address the tendons themselves, then yes, that also applies for the upper extremity. I would say for the rotator cuff doesn't quite respond the same as a lot of other tendons. But otherwise, most of the tendons off the top of my head would respond the same way. But again, it depends on kind of what you're going for the upper body. If you are looking to build more strength, then yeah, the higher weight and lower reps would be better. But that for runners, it doesn't quite apply as much.
And good mechanics, right?
Yes.
What are your thoughts? I get this question a lot in terms of arthritis. So someone comes to the clinic and they've got some joint arthritis, good range of motion, good strength, and they want to kind of know, what do I need to do with this? So knees, hips, that sort of thing. What are your typical recommendations for those athletes?
Yeah, I would say if they if there is like any pseudo gapping or anything like that of the knee, and they really want to keep running, I'd probably consider like an unloader brace. For overall for osteoarthritis, sometimes doing like kind of a run walk is a little bit better strategy. Potentially, I mean, certainly strengthening around the joint is always a good idea too. You can consider doing a gait analysis to see if there's maybe any way that we can offload it a little bit more. But I never tell any, or very rarely tell somebody stop running. that would have to be like basically they have subchondral, insufficiency fracture, and they have a lot of pain at their knee because they have minuscule extrusion and no articular cartilage. And I might say we really need to discuss things here. And if the unloader doesn't work for them, but I so rarely say. Can't think of the last time. I think it was just that scenario where I was like, we might not be able to run a lot more here. Otherwise, I say, yeah, we got some strategies. We can do some activity modification and try and build up those muscles and see if we can keep it going.
Awesome. I'm the same way. If I can keep people running, then I do. And even if I maybe want to back them down a little bit, I let them know that, but
Yeah,
try to keep that quality of life piece of things. If there are any
exactly.
other questions, feel free to throw them in the chat. Oh, I got one more. So the question is about overall recovery as we age. So typically, people are spending more time on recovery, strength, and focusing on consistent running 3 to 4 days a week. What are your thoughts on that? Do you have other suggestions from the recovery standpoint?
Yeah, recovery for all workouts can take a bit of a hit, unfortunately, as we age. Um, that's one that we might just have to consider more cross training, and potentially instead of doing a lot of longer runs, maybe a little bit higher intensity, and kind of mix that in with longer runs. But um, yeah, that's the cross training might have to kind of supplant some of those longer runs, some of the higher intensity runs, and just have almost more of a mix rather than just kind of go run. You can always consider, if things are really pretty sore, even swimming, even stationary bike, road bike, something like that, rather than straight running. But of course, if you're on a marathon training program or any sort of running training program, might consider talking to a coach or something to make a lot of changes if you're really struggling with the recovery.
Agreed. And comprehensive care, I think, is so important for the runners, and pulling people back, I feel like, is what I'm doing the most of in clinic these
Yeah,
days. So,
yeah.
um,
Especially if if the soreness is like in the tendons themselves, then yeah, see somebody for that.
yes, so some good training on what pain is okay pain and what is not. And I'm frequently having that conversation of, yeah, soreness after running I consider that equivalent to pain during running. We need to pay attention to that just as much,
Mhm.
if not potentially more, because it's not going to hold you back quite as much as that pain that you warm up out of from that Achilles tendon discomfort. So,
Yep.
um, all right.